Right, I'd like to go through today examination of the knee joint. Whenever you're examining the knee, you need to expose your patient well, and that is wearing a pair of shorts and no shoes and socks. What you might want to do also is to actually examine the patient's shoes, because that may give you some idea as to whether or not they're overloading one side or another. And that can give you some idea if they're going to have some knee problems. The next thing you're doing is just looking at your patient in a standing position. And what you're looking for here is there any muscle wasting? So we need to pull that up a wee bit. And the muscle wasting that you're looking for is in the quad, or turn your patient around, please. And you're looking for any muscle wasting in the legs here. Whilst you've got your patient in this position, look at the back of the knees as well to see if there's any swelling in the popliteal fossa. Turn around as well, Andy, please. And you're looking at the front as well for swelling to see if there's an effusion in the joint or any bony abnormality that's there. You're then looking for, is there any twisting called femoral anteversion of the femur here? And if that's the case, what you'll see is the patellae pointing in, so-called squinting patella sign. You're looking as well to see if he's got any varus or valgus deformity of his lower leg. And then you're looking at the feet, the position of the foot, the arch of the foot, and whether he's pronating or supinating. And what you're then going to do is to get your patient to walk. Just walk forwards, Andy, towards that mark there. And then back to me. And what you're looking there for is the knee extending fully, and also looking at the feet again. We're now going to put our patient onto the couch here to examine his knee on the couch. Right, we now have our patient in the position here on the couch, and we're going to do the same process again. What we're going to do is to look, feel, move, and then do our special tests. Now, we need to expose our patient again, so that gives us the chance just to cover up this Everton sign on his shorts. Right, so we're looking. Does he have an effusion here, swelling in the knee? Once again, can we see on closer inspection, are there any scars here? Has he had arthroscopies or any other form of surgery? Does he have any wasting of the muscles here? Now, it's sometimes easier to see in this position than it is in a standing position. And what we're looking for here is wasting in this area of the medialis. Now, if we do think that there's any problem here, we would want to measure this. And what we do is to measure from the proximal aspect or superior pole of the patella, measure 4 inches, and then do the circumference. And we do it on both sides. It's said that a 2 centimetre loss of circumference will give you a 30% loss of strength. So it's important to know if there is any wasting here in this muscle. The slight problem with that is if the patient has an effusion, then the patella may be either pushed upwards or downwards slightly. So in that situation, what you might want to do is to feel for the medial joint line, straighten up the knee, straighten the knee, and then measure from the medial joint line, and then you're sure that you get the same point on both sides. The next thing we're going to do is to palpate. And what we're going to do is to feel, see if the temperature is any different. If the joint is hot, that means that there's either some inflammation or infection within the joint. You may also see some erythema in that case, and that's something else to look for in your inspection. Once we've palpated for temperature, we then palpate the structures around the knee, and you start with the quadriceps tendon, and then you come over the top of the patella, and you're feeling here for any tenderness. And you feel the inferior pole of the patella, and what you might want to do is to push down on the top, reflect the inferior surface, and push again. And you're looking at your patient's face to see if there's any discomfort. All right. Then you follow the patella tendon down, looking again for tenderness, down to the tibial tuberosity, which may well be uncomfortable in a condition such as Osgood-Schlatter's disease. Once we've done that, we're going to palpate the joint lines. Start with the lateral joint line. You're looking at the patient's face to see if there's any tenderness. Any tenderness? No. And then palpate the medial joint line. Once again, looking for tenderness. So the joint lines are non-tender. If they are tender, you're looking at, is there a ligament or a meniscal problem? Deeper structures might even be, is it an arthritic problem? Or things like osteochondritis dissecans can give you some discomfort on palpation there. You need to remember that the ligaments go slightly above the joint line and below. The lateral ligament is a cord-like structure that goes just above the lateral joint line and then inserts into the head of the fibula. The medial ligament is a much longer structure, between 6 and 8 centimeters in length, and comes from the femoral condyle and inserts down in the tibia down here. So that's the palpation. That's your palpation. You want to palpate at the back as well to feel if there is any popliteal swelling, such as a Baker's cyst. What we're then going to do is with the effusion test, just relax your leg, is to brush down any fluid from the suprapatellar pouch and then do a sweep test. And what you're looking for is a bulge, when you're doing that, a bulge on the other side and an indentation on this side. And if there's an effusion, you'll see the bulge here, and then you go down the other side, and then the bulge comes on this side. If it's a very small effusion, you do have to milk the fluid down. There's normally about 4 mils of fluid in a joint, and if you get an effusion, a small effusion, you often have to milk it down in order to actually see it. Right. What we're going to do next is to examine his collateral ligaments. Whenever you're doing any specific tests here for joints, especially the knee joint, it's really important that you actually get your patient in a relaxed position. Because if he's tight in his quads or his hamstrings, then what's going to happen is those structures are going to contract and make any of your testing very difficult. In that respect, it's quite important, any tests that are particularly uncomfortable, and I'll come on to a couple of those later, you leave those till last, because once you've produced a lot of pain from the joint in the patient, your chances of examining them properly then have gone right down. Right, so medial, I'm going to test his medial ligament first of all. You do this in 2 positions. You do it first of all with a patient with an extended knee, and what that's telling you is the structures that are tight in that, normally tight in that position, if they are also ruptured as well as his medial ligament, then you know that it's a fairly serious knee injury. So if you've got an opening up of this joint with the knee in extension, then you know your patient has got major trauma to both the medial ligament and other structures there in his knee, such as his cruciate ligament. Flex the knee to about 20 to 30 degrees and put a valgus force on the knee, and you're looking to see if that joint opens up, and if so, is there what we call a soft end point or a firm end point. And you're looking for a firm end point where the actual ligament is holding that joint nice and firmly. You then compare it to the other side in order to see if there is any difference. Examining the integrity then of your lateral ligament is you do the same examination, only you go into varus rather than valgus. So you're pushing the foot inwards and you're testing to see whether or not there is any laxity in that lateral collateral ligament. Another small test that you can do for the lateral ligament is to get your patient to cross his leg like this, and you should, on the lateral side here, feel of the cord-like structure of his lateral ligament. If you can't feel that, then that means that the patient has got a rupture, and it's normally a complete rupture of that ligament. Right, the next test I'd like to show you is a McMurray test. We're thinking now about looking at the cartilage here. And the McMurray test is you put your patient up into full flexion, you put your thumb on the outside and I tend to use my middle finger on the medial joint line, and you put your patient in full flexion, and then you go into lateral or lateral rotation of the tibia, and then you extend the knee joint. And what you're looking for there is that painful, and do you feel a click? And then you do the same by rotating the foot medially and doing the same again. Now, when you go laterally, you're testing for the medial meniscus, and when you go internal rotation, you're testing for the lateral meniscus. Now, if you're not sure of that test, just sit forward, Andy. Then you can then go on to, just turn over for me, what's called the Apley grind test. Turn right over. And remembering which knee it was again. What you're then doing is what you're doing here is you're just rotating the foot medially and laterally, and you ask your patient, is that painful? No. Then you're doing the same with downward pressure on the foot, and you rotate medially and laterally. Is that painful? No. Now, if you've got a meniscal tear, that's called the Apley test. That's going to be painful either on the inside or the outside of the joint. Be slightly careful with that one. If you've got a medial ligament tear, then that test can be painful with both compression and with no compression. And turn over again for me, Andy. Right, the next test that I'd like to show you is for cruciate ligament injuries. Now, when the cruciate ligament ruptures, you often get a very good history of that, which may actually tell you that the ligament has actually torn. The test that you can do for that, there's two main tests. One is called a Ligament test, and the other is the pivot shift test. Now, the Ligament test, once again, it's really important you get your patient well relaxed. And you bend the knee to about 30 degrees of flexion. You hold the femur with your left hand, and you hold the tibia with your right hand. And what you're trying to do is put anterior, just relax, nice and relaxed, anterior force on the tibia, and you're trying to pull it forward. And what you're looking for here is an increased translation of the tibia. Now, another way to do this test, if your patient is either very big or can't relax very well when you've got them in that position, is put your knee on the couch or a pillow underneath here and get the patient nice and relaxed, and then do the same again. Fix it with the femur with your left hand and then pull up with your right hand. Now, the Ligament test comes in 3 grades, grades 1, 2 and 3. A grade 1 Ligament is up to 5 millimeters of anterior translation of the tibia. Between 6 and 10 millimeters is a grade 2, and more than 10 millimeters is a grade 3 Ligament test. The slight complication here is the Ligament 2 has 2 grades. It has an A and a B. And Ligament A it has a good end point, which may indicate a partial rupture. And a grade 2B, it has a very soft end point. And if I can just give you an example of how to feel for that end point, if you just have a little piece of cord or rope, and what should happen, because the ligament is at an angle here, when the tibia comes forward, this rope is tight. What happens with a tear is you just get a very soft end point, so that there's no catch there at the end. Right, that's the Ligament test. The next test for anterior cruciate ligament rupture is called the pivot shift test. This is a difficult one to do, and you need good experience to do this, especially in an acute situation if a patient has any soreness in his knee, because this test can be uncomfortable. But the test is put the patient in full extension of the knee. You medially rotate the foot. You put the knee into a valgus force, so I'm pulling outwards, and then you bend the knee. And if you've got a cruciate ligament tear, when you get to about 20 to 30 degrees of flexion, the IT band then pulls the tibia backwards, so you get a clunk. And what you're looking for is the tibia being pushed backwards when you get to that degree of flexion. Just so that we actually have completeness here, there is a test called a reverse pivot shift, where you're looking for the posterior cruciate ligament. However, I wouldn't recommend that test, because 35% of normal knees have a positive reverse pivot shift test. Okay, I've come over this side and moved the camera angle slightly so that we can just look at a couple of tests for the posterior cruciate ligament. The posterior cruciate ligament is examined. Your patient to bend the knees up to about 80 to 90 degrees. And what you're looking for, you're looking across the patient's knees to see whether there is anything called sag of the tibia backwards. So this, Andy's got no problem with his posterior cruciates, but if you had, you would see, when you look across here, you would see this area pushed back slightly. Now then, there's something called the quadriceps activation test, where, because you've got the sag there, if you get the patient to contract, say we're looking at his right knee here, just contract your quad on this side, Andy, and relax. Okay, and do that once more. And if you've got posterior cruciate ligament tear, what you would find when he contracts this muscle is that the tibia is pulled forwards. And that's the quadriceps, it's a test of the quadriceps muscle here. Right, the final test that I'm going to do here on the couch is called the dial test. And the dial test, sit forward Andy please. The dial test is looking for what's called posterolateral instability. And if you've got a tear of the posterolateral corner, plus or minus the posterior cruciate ligament, then this test is a good one to do. Turn over for me, Andy. And what you're doing is you're putting your patient into a prone position, and you're bending. I normally do this from the end of the couch, but for the camera, I'll do it from here. And you're bending to about 30 degrees of flexion, and then you're going into external rotation. And you're looking for a difference between the two sides. And the difference when you've got a posterolateral corner tear is about 15 degrees normally. What you then do is you go up into 90 degrees of flexion and do the same test. Now, if you've got a posterolateral corner tear, you're then looking for a difference of only about 5 degrees. However, if you've got a posterior corner plus PCL tear, then you're looking still for a difference of about 15 degrees of external rotation. That's called a dial test, and it's for posterolateral corner problems. Turn over for me, Andy. And lie back. And then just a couple of tests for the actual patella. You're looking for any instability here in the patella. So the test for that would be called an apprehension test. And you're looking, if a patient has had a dislocation of his patella, this is the test to do. So what you're doing, you're looking at your patient's face when you do this test, getting him nice and relaxed, so his quads are nice and relaxed. Then you're pushing the patella into lateral deviation and bending the knee. Bend your knee. And if a patient has had a dislocation of his patella, he won't want you to do that, and he will look very apprehensive or tell you he doesn't like it. A few patella dislocations are medial, majority are not, but a few are, so you also do that medially. And you're looking at your patient all the time. And finally, of the patella, the Clark test, which is looking for retropatella or roughening behind the kneecap. Push down on the patella and ask your patient to contract their quad, contract. And you're looking to see if that's an uncomfortable experience, or you're looking for crepitus behind the patella. Final test to do in a standing position. Can we get you standing up now? Go on that side. Okay, just like that. This is called a Thessaly test and is the final test for meniscal tears. And what you do, you get your patient to stand on the unaffected leg first of all. So just stand on your left leg, and then you hold on to your patient like this, get them to flex to about 20 degrees, that's fine, and then rotate on that knee and rotate the other way. And you do that 3 times. So he gets the hang of that. And then you get him to stand on his Everton leg, which is the bad one, and you rotate again. And you're looking for pain, either in the medial or in the lateral compartment. That's the examination of the knee. Thank you very much.